Hi, Shweta, you can reshare your slide.
Yeah, I'm so sorry. So today's iFocus online session with Dr. Pranita Sahay, who's completed her MBBS at Patna Medical College with a gold medalist. She's also finished her MS Ophthalmology at RP Center for Ophthalmic Sciences from AIIMS New Delhi. She is an awardee of FRC Opt, FRCS Glasgow, FICO Cornea, FAICO Refractive Surgery, DNB, and FICO. She's currently the Assistant Professor of RP Center for Ophthalmic Sciences, AIIMS New Delhi. She's an executive member of the Delhi Ophthalmological Society. She's also the ex-senior resident from AIIMS New Delhi. She's an ex-faculty at the Honorary Institutes of MAMC, LHMC, UCMS, CFS New Delhi. She has more than 88 PubMed indexed publications, authored one book, 27 book chapters, received the Best Scientific Paper Award in Karakon 2018, the ISCKRS in 2019. She's also the convener of the Surgical Skills Transfer course in AIOS 2023 and 2024. We are extremely humbled and honored to have you here, ma'am. Over to you.
Thank you, Shweta, for that kind introduction. And at the outset, I would like to thank Dr. Hunawar for giving me this opportunity yet again to be a part of the iFocus team and presentations, and also to Dr. Praful Marana for letting me author in his esteemed books of Ophthalmology Clinics, in which I had contributed to a chapter of ophthalmic instruments on which I'm going to be talking about today. So, as you know that in your postgraduate exams, ophthalmic instruments is also one of the station on which you have a viva. So usually a box of instruments is kept in front of you and there are jargon of instruments. And the usual question from the examiner is identify this instrument, or either they ask you to identify a particular instrument or they ask you to pick up any of your preferred surgical instruments. So it is always better that you have 2 or 3 instruments in mind with which you are well prepared to talk about. So the usual questions are to identify the instrument, then describe its part, what are the uses of that instrument, and the advantage and disadvantage. And often if the instrument is related to a particular specialty surgery, then the detailed surgical steps of that specialty surgery, or the indication, contraindication of those surgeries, and detailed, specific details of those surgery can be asked about. So that is what you need to be prepared. So today we'll be dealing about all the different specialty surgeries. I'll be talking about instruments related to cataract, cornea, and oculoplasty. And the next speaker, Dr. Devesh, will be talking about retinal surgery, instruments related to retinal surgery, squint and glaucoma. So moving on to instruments for cataract surgery. So now instruments can be as basic as speculum. We use it day in and day out, but we usually do not think into the depths and detail as to what questions can be asked about it. So first you need to understand there are different designs of speculum that are available. The picture that you see on the left is that of a universal metallic speculum, universal metallic eye speculum. So why do you call it universal? Because it can be used for either right or left eye, and it is not specific to the side in which it is being used. That is why it's called universal. The advantage of this is, first, it can be used for either right or left eye. Second, it is light in weight, and therefore it causes minimal pressure on the globe. However, the disadvantage here it is that it cannot keep the eyelashes away. Okay. The other design of the speculum is the self-retaining Barracker eye speculum that you see on the right. Now, the advantage here is, in addition to the normal speculum features that you see here, you also have a screw at the end, which when adjusted can, you can adjust the amount of exposure that you want. So with the tightening of the screw, you can increase the aperture opening of the eyelids and, accordingly adjust the exposure of the eye. The disadvantage with this is it causes, because this is more bulky compared to the universal metallic eye speculum, it is going to cause pressure on the globe, and it also increases the intraocular pressure. So you need to be careful about it. The uses, it is used in almost all ophthalmic surgeries except those related to the eyelid. It can also be used for examination of eyes in children, for corneal scraping, removal of corneal foreign bodies. Now, moving on to forceps. Now, there are different types of forceps. They can be either tooth forceps or non-tooth forceps. Among tooth forceps, the common forceps that we use are the limbs forceps. It is used to fix the eyeball during any procedure and also to give counter traction when you're making any entry into the anterior segment. What you need to understand, it has a curve at the end. It has a convexity towards the upwards convexity and tooth at its end for better grip and better holding. Then you have a superior rectus holding forceps. Now this looks similar to your limbs forceps, but the difference is it has an S-shaped curve at the end. So it has a long S-shaped curve, which is designed to fit into the orbit, superior orbit, while trying to grasp the belly of the superior rectus muscle. And the main uses of it is for brittling of the superior rectus, predominantly in ECC and SICS surgery, and sometimes even in trabeculectomy surgeries. Superior rectus brittling is done, for which this forceps can be used. The next important instrument is a colibri forceps. Now, this has a fine concave curve towards the upside and fine tooth at the end. So this is used for holding fine structures like the scleral flaps or cornea while suturing, and also for holding of the iris for doing surgical PIs. Next is the glow fixation forceps, in which it is a more stout or a bulky instrument and multiple tooth or serrations at the end, which is used for holding the conjunctiva and the episcleral tissue near the limbus. Now coming to the non-tooth forceps. So these are some of the non-tooth forceps that may be present in your examination table. McPherson forceps is something which we very commonly use. So it has an angled tip, although the tip looks sharp, but it is almost blunt and it is not toothed. It is used for holding the IOL, for suture tying, for implantation of the non-foldable IOLs as well. And it is atraumatic. And it is important to remember, since it does not have tooth, it does not have a good grip when you're trying to hold soft tissue. Next is your epilation forceps. Now, epilation forceps at the end has a blunt and flat end. It is almost like a small flat plate, which when gets opposed can hold the lashes or cilia very well. So it is used for epilation of cilia in trichiasis, distichiasis, and style, and even in electrolysis procedures after the electrolysis for removal of the eyelash. Now, next is your artery forceps or artery clamp, also called as hemostatic forceps. Now, they are again blunt tip forceps, which can be either straight or curved. They have multiple serrations to, oppose the tissue well, and has a locking mechanism to achieve good hemostasis, and so that they have a good apposition for a prolonged time. Till the time you do not release the lock, it is going to oppose the tissue and achieve good hemostasis. So what are the uses of this instrument per se in ophthalmology? So per se, this artery forceps are used in squint surgeries to crush the muscle before cutting them. So in resection surgeries, before you cut the muscle, it is used for crushing it so that it doesn't bleed. And also in orbit surgeries for holding the bleeders in the soft tissue in the orbit. Next important instrument on which often examiners like to question the residents is the Utratus capsulorhexis forceps. It looks very similar to your McPherson forceps. The only difference here, if you see, is the tip. It has a fine angulated tip with sharp points. It also has an iris platform, as you can see in this top image. There is a knob in between. It is an iris top platform which is present at approximate 8.5 millimeter behind the tip. Now, the main purpose of having this iris top platform is that once you try and oppose the forceps completely, even though your tip will be completely occluded, the shaft of your forceps is not going to close completely, and hence there is no risk that your iris is going to get incarcerated or stuck in your forceps. So that even when your distal tip is closed, your proximal part of the forceps remains open, avoiding holding or inadvertent grasping of the iris in this forceps is the function of this iris top platform. So the uses of this forceps, some people like to use it for routine capsulorhexis. However, predominantly its use is in cases where you expect a difficult rhexis, especially in cases of subluxated cataract, a mature senile cataract, intumescent cataract, where you expect a rhexis runout. So as you can see here, this is a subluxated cataract, almost 6 o'clock hour subluxation. So the risk of rhexis runout, especially in the area of zonular weakness, is high. And in such cases, you can have a good controlled rhexis with this capsulorhexis forceps. It is important also when you're naming this instrument that you remember their full name. Like one, you can just say a capsulorhexis forceps, but if you say it's a Utratus capsulorhexis forceps, the examiner is going to have a is going to feel that yes, you're well read about the instrument and you've made an effort to read specifically about the instruments rather than just the subject. So also when you're talking about Utratus forceps, some common questions like you may be asked about how will you manage a running out rhexis, or what is Little's maneuver to manage a run out rhexis. So these are some things that you need to know when you have this instrument in hand. Now, certain modifications or modern instruments for capsulorhexis include the microcapsulorhexis forceps and the Haldipurkar's microcapsulorhexis forceps. So the size of incision required for a routine Utratus capsulorhexis forceps is 2.2. That is, you need a main port incision for the routine capsulorhexis forceps. So these instruments were devised so that they can be used even through a side port instrument with a more stable anterior chamber and a more stable condition, intraocular condition, to have a better controlled rhexis. Now, since majority of the surgeries are now being done in topical anesthesia, hence to have a good fixation of the globe, and routinely in block surgeries, you can hold the conjunctiva or the limbus with the limbs forceps, but it causes pain when you hold the conjunctiva with such instruments in topical anesthesia. Hence, these Hoffman-Thornton globe fixation rings have been devised, which can be placed on the limbus for appropriate fixation of the globe at the time incisions are being made. So this does not cause pain and also gives you a good fixation of the eye. Now, moving on to the next instrument is your cystitome. That's a 26, usually prepared with a 26 gauge needle or an insulin syringe. So it is nothing but a simple 26 gauge needle, which is bent at two ends, one at the distal end with a 90-degree angulation, and with the and the other being at a 120-degree angulation, which is closer to the hub at approximately 15 to 16 millimeter distance from the tip. And you can use a Castrovigio's you can use a caliper to mark the distance from the tip at which you're comfortable to make the second angulation. You usually use a needle holder to make this prepare a cystitome needle. At the distal end, the bevel is turned up to make a 90-degree angulation, and the second angulation is made at around say 15 to 16 millimeter behind the first bend, and it is usually a 120-degree bend. So this is how you prepare a cystitome needle. The next instruments are the Sinskey and chopper for cataract surgery. These are very important, instruments for side port instruments. Now, although they may look very similar, whenever you're trying to comment upon this instrument, first try and hold this instrument in your hand to have a very close look on this instrument before you comment upon whether it's a Sinskey hook or a chopper. The predominant difference is at the tip. The Sinskey hook is an absolutely blunt tip and short in length, while a chopper, the tip will have a longer length and it may be sharp or blunt, either ways. Now, the Sinskey hook is used to manipulate the nucleus for dialing the nucleus after you have done your hydrodissection and delineation. It can also be used to dial the IOL after IOL insertion, used to stabilize the globe during phacoemulsification as well, while the chopper is used for cracking of the nucleus. Now, the phaco chopper can be of 3 different designs. Whenever you have a chopper in hand, you will be asked about the different chopping techniques and the different types of choppers. So you need to know that the chopper can be either a sharp chopper, which is predominantly used for a vertical or a central chop, wherein the chopper and the phaco probe are used to split the nucleus and they are moved 180-degree apart to crack the nucleus. And the second type of chopping is your horizontal chop or a peripheral chop. It is done with blunt choppers. But in this, the chopper is taken beneath your capsulorhexis margin till the equator, and from the periphery, the chopper is moved towards the phaco probe to have a horizontal splitting of the nucleus. So this requires some expertise. For beginners, a vertical chop is what is advised. You can also have hybrid type of choppers which have a blunt tip and sharp cutting edge. So next, moving on to the blades. The blades can be a side port blade or an MVR blade. So what does MVR stand for? It is microvitreoretinal blade. Now, this MVR blade is usually used to make a side port incision or a paracentesis. And this instrument can be either in a straight, it can be a straight instrument, or it can be angled. So why an angled or a straight? So normally in cataract surgery, majority of the surgeon use a straight MVR blade. However, in deep set eyes, or especially when you're making nasal entries where the nasal bridge is prominent, using a straight blade may be difficult. In such a case, an angled MVR blade may be helpful to make the paracentesis incision easily. Now, the size of the paracentesis blade or the side port blade is also important. It comes in various sizes, varying from 19 gauge to 25 gauge. 20 or 21 gauge is what we routinely use. 21 gauge is 1.1 millimeter and 20 gauge is 1.2 millimeter. Because if you make a larger incision, side port incision, your wound may be leaky and you may have a shallow anterior chamber because of continuous fluid leak. So an appropriately sized side port entry is also important. So whenever you're making a side port entry, it is important to support the globe on the opposite side for a good counter traction to have a controlled entry into the anterior chamber. So this is how an anterior chamber entry can be made with a side port or a MVR plate. Moving on to the next one is a disposable keratome. Now, they have a diamond-shaped apex, as you can see in the diagram above. They are diamond-shaped apex with sharp edges on both the sides. So cutting action is present on both the sides, and they are almost always angulated. They are used for making volvular corneal incisions and self-sealing incisions. So an initial marking can be done with this incision to mark the position of the entry, following which further entry can be made into the anterior segment. Now they come in various sizes, 2.2, 2.8, 3.2, and 5.5. Depending upon which surgery and which procedure you're doing, you have to choose the blade appropriately. That is again important to have a watertight compartment. For example, if you're using a phaco sleeve with a 2.2 mm phaco sleeve, then you need to use a 2.2 keratome for making the making the main port incision. Now, when you have a keratome in hand, the usual questions will be that what are the different types of corneal incisions. So you need to be aware of the different types, sites of incision, the scleral, limbal, corneal advantages and disadvantages of each, and also the 2-step, 3-step entry, and everything needs to be known in detail about corneal incisions. So moving on to the next instrument is a crescent blade. Now, this is a blunt-tipped instrument which has a bevel side of the knife up, and it has a cut splitting action on both sides. As you can see in this video, they can be used for creating scleral flaps. They can be used for making scleral flaps. And the other uses of it are in pterygium surgeries. Scleral flaps can be made for CONE implantation, for SFIs, DSEC, SICS, TRAP. And it can also be used for making lamellar corneal dissections, especially in DALC surgery. So this is, again, you need to be aware of this instrument. Phaco handpiece is usually not there in the examination, but you can have an OSCE-based examination for the instruments as well, in which you can be given a picture of this. So I think this has already been covered in your phaco dynamics, and you need to be aware of all the different parts of the phaco handpiece. Now, phaco tip can be there in your instrument box in the viva. The tips can be of different design. You need to be aware of all the different design. The top is your standard tip, where it is a straight needle. You need to be aware of the diameters. Inner diameter is 0.9, outer diameter is 1.1. One with a downward angulation of 22 degrees, which is around 3.5 mm from the tip. This is a Kelman tip. You can have a balanced tip, which shows a double angulation. And these are specifically useful in patients with hard cataract and deep anterior chambers. You also have other modification, but these are the three common tips that can be present in your instrument station. You also should be able to identify the angulation of the tip, the bevel. It can be either 0 degree, 15, 30, 45, and 60. The advantages of a 0 degree tip over a 60 degree tip, you should be aware, and you should know that the 30 degree tip is the best, which gives, a best compromise between the occlusion and the cutting. Okay. So in this, the cutting and occlusion is both balanced out, and hence a 30 degree tip is what is most commonly used. Now you have different types of needle holders. You can have a Barracker needle holder, Castrovillo needle holder, Arrugas needle holder, and you should be aware of all these three. So the Barracker's needle holder is, you can see it has a fine C-shaped curve at the end, and it has fine serrations at its jaw for a good hold of the needle. It is very useful in passing sutures through fine structures, especially the conjunctiva, cornea, sclera, and extraocular muscles. In keratoplasty, predominantly the corneal surgeons prefer a Barracker needle holder for keratoplasty surgeries. While the Castrovillo needle holder, the needle holder has a locking system, and the tip is usually, it can be either straight or curved, but it does not have this specific C-shaped angulation. It is usually used for squint and buckling surgeries. So you should be able to differentiate between the Barrackers and the Castrovillo needle holder. The next needle holder is your Arrugas needle holder. It is quite different. It has a flat plate on the top for placement of a thumb. It has a locking system here, and the tip is where your needle gets engaged. So this is basically a large needle holder predominantly for superior rectus bridling and for eyelid surgeries as well. Moving on to scissors. Now, this is a tenotomy scissor, which the full name for which is a Steve tenotomy scissor. It is a plain scissor with a blunt end, and it has two designs. It can be either curved or it can be straight. It is used for cutting the muscle and also for blunt dissection of the soft tissue in squint and oculoplasty procedures. Now, a large instrument like this is the Westcott conjunctival scissors, which has a lightly curved blade. And you can see there are multiple holes in this instrument. The purpose of holes in these instruments is just to have less metallic content, to make them light in weight for use during the surgery. In these scissors, one of the end is usually blunt and the other one has a sharp tip. And they are, you see, in any instrument which has such a locking mechanism in the sorry, I have a bad cough. So any instrument that you see with a locking mechanism at the end here works by a spring mechanism. That is, only when you press on this instrument, that is, the scissor blades are going to get opposed. The rest of the times, the blades are not going to get opposed without any pressure. So this is to just avoid any inadvertent damage to the tissue or any inadvertent cutting. Only when you press this instrument will the cutting mechanism action occur. Otherwise, the blades are going to remain open and will not damage the structures. So it is overall length, you don't need to remember, but okay. So now is the Castrovillo corneal scissors. Now the size of this is smaller than your conjunctival scissors. This is a fine curved scissor. Again, has a spring action. As you can see, it is then engaged at the end. And it is used for making the large corneal incisions like in your ECC surgeries and keratoplasties. So this has, the blade of this is smaller than that of your conjunctival scissors, but the curve of this is used to match the curvature of the limbus. And you can cut the corneal tissue easily with this instrument. Now, one scissor is a smaller instrument than your cornell scissors. It is small, fine, and more sharp. So the blades are sharp. It comes in 3 designs. It can be the curved, straight, or angled. For corneal procedures, usually curved scissors is what is preferred. For cutting of the sutures, you can use the straight scissors. However, when you're making some, say, scleral flaps or in trap surgeries where you have to cut the scleral flaps, in such situations, the angled ones come in hand. So the main uses we've already discussed: to cut the sutures, for making iridectomy, even for capsulotomies, they can be used for cutting the scleral flaps. Now, this is not a very common instrument, but sometimes some places you may see this instrument in your exam box. It is a De Wecker scissor. Now, you can see there are 2 fine plates. With the help of the thumb and index finger, you can press this, and the fine scissors at the end, when you press the 2 plates, the scissors get opposed and you can have a cutting action. So they are used predominantly for iridectomy and cutting the vitreous strands that are prolapsing from the wound. Although ICC and ECC are not very commonly performed, but for examination purpose, these instruments definitely hold value, and they are asked about in the exam to postgraduate students, so you should be aware. Now, lens hook is an instrument that has a metallic handle with a J-shaped loop, and it is used for applying pressure at the limbus for counter traction at the time of delivery of the nucleus in ECC. Now, this is a lens spatula. It is again has a metallic handle with a spatula or a flat end, which usually a spoon-shaped appearance at the end. And this is again to apply pressure at the 12 o'clock position for expressing the nucleus and ECC in ECC procedures. Now, this is the Aruga's intracapsular capsule holding forceps. Now, as you can see on the tip, and this tip has cups. So it has cupped ends on both the sides, and it has blunt end. So it is an atraumatic forceps for holding the lens capsule for holding the lens with these cupped ends to deliver the lens in toto without rupturing the lens capsule. So this is in ICCE surgeries when the lens extraction is done, when the lens is delivered in total without doing a capsulotomy. So when such an instrument is there in hand, definitely you'll be talked about the different techniques of lens delivery in ICC. You need to be aware of the different techniques like cryo extraction, irisopic, the Indiana Smith method of delivery, and the capsule Aruga's method of ICC. Next is your IL holding forceps. This is nothing but a blunt forceps blunt forceps with an angulated tip, specifically designed for implanting the non-foldable PMMA IOL. Next is your wire vectis. As you can see, this has a metallic handle with a ring at the end, a ring or a loop at the end, with the central area being empty. So this is basically for your delivery of the nucleus in ECC. It can be either a non-irrigating wire vectis like this one, which has a metallic handle, or it can be an irrigating wire vectis in which you have this ring is not a stout ring. It has a hollow rim with a 0.3 millimeter opening here through which fluid can come out. So basically it's a cannula to which you can attach an irrigating system. Fluid will go into the hub to this ring and come out through the hole. So basically, when you're trying to deliver the nucleus in ECC like this here, a vectis is taken inside beneath the nucleus, and the nucleus is delivered. If you have irrigation system attached to your irrigating wire vectis, with the fluid irrigation, you can the posterior capsule remains cushioned, and the risk of having a posterior capsular rent or a damage is less because the continuous irrigation is going to push your PC behind while you're trying to deliver the nucleus. So that is the basic difference between the two. Then you have the Dastur's iris depositor, which is nothing but a blunt instrument, a blunt spatula, which can be even inserted through a side port. And it is basically used in patients who are having prolapsing iris for reposition of the iris. Since it is blunt, it is atraumatic, does not cause iris damage or a lot of iris atrophy. And risk of iridodialysis is also less if you use this instrument for iris reposition, is what you need to be telling about this instrument when the examiner asks. So it is in other uses other than the iris repositioning is even in keratoplasty, we use it for tucking in the graft after the suturing has been done. Now, this is the irrigation and aspiration instruments used for irrigation and aspiration. You can have a Simcoe irrigation aspiration cannula, which is used for manual. It's a manual method of irrigation aspiration. This can be attached to an fluid bottle, which is connected to to a plastic tubing connected to the Simcoe cannula here. And with this, you can aspirate with the help of a 5 ml syringe, which is attached to the other end. With the aspiration through the 5 ml syringe, you can remove the cortical matter from the bag. Specifically in ECC surgeries or SICS, where you may not have access to sophisticated phaco machine, manual removal of the cortical matter can be done with the help of a simple instrument like Simcoe irrigation and aspiration cannula. Now, if you have access to the phaco machine, the instruments that you will use will be either a bimanual irrigation aspiration or a coaxial irrigation aspiration. So in bimanual irrigation aspiration, the irrigation and the aspiration function is split between the two instruments, and the removal of the cortical matter can be done easily. The use of the two instruments is based on the surgeon's comfort. However, in cases where you have a subluxation and you want to split the fluid direction and the aspiration, then you can use an irrigation aspiration bimanual cannula. Moving on to the next, anterior vitrectomy probes are usually not kept, but sometimes you can be asked about this if you have an OSCE-based examination for your instruments. Hence, you need to be aware about the different types of vitrectomy cutter, rotatory cutter, oscillatory mechanism or payment type cutters, and the Gallatin type cutters, which is the current type of vitrectomy cutters that we use. So what is Gallatin type vitrectomy cutter, or the current type of cutter that we use? It basically has an outer tube and an inner tube. While the outer tube is fixed and has an opening port, the inner tube slides slides in it, and because of the sliding movement, it cuts the vitreous that is getting engaged onto the port present in the outer tube. So it does not cause spooling of the vitreous, and it cuts the vitreous very efficiently without causing any traction. Here you can also be asked about the different modes of the on the vitrectomy machine, IA cut, IA, when to use what, you should be aware. So whenever you have to remove a cortical matter or a remnant of the capsular bag, you will go with an IA cut mode. While if you want to remove just the vitreous and it is predominantly vitreous which is present in front, then you have to go with a cut IA mode. Now the parameters also need to be known, about which we'll not go into so much details here. Now these are the different types of IOL injectors. What you need to know about them are they use basically for injection of the foldable IOLs. So foldable IOLs can be injected by either a push type plunger or a screw mechanism plunger for implantation of the IOL. So what is the advantage and disadvantage? With the screw mechanism of plunger, the injection or insertion of the IOL is very controlled. You do not have a sudden release or a sudden jerk in case if your injector is old. Sometimes there may be jerky movements in a push type injector, but with a screw type injector, you will never have a jerky movement. The injection is very smooth. However, the disadvantage of a screw type injector is that both the hands are engaged, one for screwing and the other for stabilizing the plunger. So wound assisted implantation of the IOL is difficult with the screw type of plunger, while wound assisted injection can be easily done with the push type of injector. So these are the differences between the two that you need to be aware. Now, we are now in the modern cataract surgery, a lot of multifocal and toric IOLs are also being implanted. So I'll be discussing about few instruments per se related to the toric IOL implantation. So this is a Newitt's Lane toric bubble marker. In this, you can see there are three grooves here, which is at 0, 90, and 180 degree. There is a fluid column here in the center with a division of this fluid column into three parts with the two black lines, and you have an air bubble or in the air bubble in the present in the fluid column. So this is basically for having a proper horizontal alignment of this marker when you are doing a toric marking. So as you can see in this video below, this is done under topical anesthesia with the patient in the standing position. You can see first the bubble is aligned into the center box in the center compartment, and only then the marking is done. And you can see good 0, 90, and 180 degree marking at the limbus on the conjunctiva for toric IOL implantation. So this is giving your reference axis, and for placement of toric phakic IOLs or toric IOLs, even for arcuate keratotomies. Now, the intraoperative marking of your IOL axis can be done with this instrument, which is the Mendes toric ring gauge ring marker. And in this, you have a 0 to 180 degree marking. You have different types of ring. You can have a 5-degree mark or a 10-degree mark in this ring. And you align the 0 and 180 degree of this instrument with the 0 and 180 degree of the reference mark that you did preoperatively. And then mark the IOL implantation axis on the cornea with the help of this degree marking that you see on this ring. Now, in non-dilating, some instruments that are used for the non-dilating pupil, this is an iris hook. This can also be there in the Viva. It is basically composed of nylon with a polypropylene sheath added to it and a silicone disc attached to the end for fixing up the iris hook. So now you need to know what are the causes for non-dilating pupil and what are the other devices used for dilation of the pupil when such an instrument is given to you. Also, what is the point of entry? Where should the incision be for implanting this iris hooks? And the main disadvantage of iris hook here is that it causes a lot of distortion of the iris and sphincter tear. You may have a permanently fixed dilated pupil post-operatively because of the damage to the sphincter tear, damage to the sphincter pupillae because of this stretching of with this instrument. However, the advantages is gives a good exposure of the nucleus. Now, the other devices that can be used for pupil expansion are Malugian ring, B-hex ring, and the Gupta's ring. Now, I'll be discussing a little about the Malugian ring because this can be there in the examinations. It is made up of polypropylene and is inserted through the main port. So here you can see a main port incision is being made. And it comes into with an injector system. So this is being you can see here the Malugian ring is being loaded onto the injector first, and then through the main port entry, it is being injected. Similar to an IOL injection, it can be simply injected into the anterior chamber. And you can see there are multiple knobs. These knobs are then engaged onto the pupillary border. And you can have a good 6 to 7 millimeter dilation with this instrument. And the main advantage is that you have a uniform dilation of the iris, hence the risk of sphincter tear is less opposed to that with the iris hooks, and the risk of post-traumatic mydriasis and iris distortion is less. However, the disadvantage is that the maximum dilation that can be achieved with this instrument is just 6 to 7 millimeter, while the iris hooks can give you an exposure up to even 8 or 9 millimeters. The next instrument is your capsular tension ring or a CTR. This is basically made up of PMMA, hence it's a rigid ring, and it is used to support the capsular bag when the zonules are weak. So when you have a bag dialysis, this is something which is used. What you need to remember is it comes in different sizes, 10, 12, 11, 13, and 12, 14.5. So what does this 10, 12 mean? That is mentioned on the box of the CTR. It just means that when you compress the ring, by virtue of the design, if you compress the ring, it will be in the size of 10 millimeter. And when it is implanted in the bag and it is completely expanded, it will expand to a size of 12 millimeter. So in pediatric cases, if you're using this CTR, a 10-12 is preferred, whereas in adult cases, 11-13 is preferred. Whereas in high myope, where you have a large bag and you have a bag dialysis, in such cases, you can even go for the largest size, that is 12-14.5. So we have already discussed this is used in cases with bag dialysis or subluxated cataract or pseudo exfoliation. Even in pseudo exfoliation, prophylactic CTR insertion is advised by few. So these are the main indications. Now, Sione ring, which is a modified CTR. This can be either a single fixation ring or a 2-point fixation. So this is basically a CTR ring with an eyelet here attached to it with a forward angulation. So this eyelet is basically sutured to a ninoproline suture, which is then sutured to the scleral flap. So if you have a dialysis, say more than 3 kilohours, say 3 to 6 kilohours, we will go for a single point fixation Sione ring. If you have a 6 to 9 kilohour dialysis, you will say that I will go for a double fixation Sione ring, wherein you have two eyelets. Hence, you will fix this Sione ring at 2 points onto the sclera for a better stability. This is how a Sione ring looks like. This eyelet is going to tent up over your rhexis margin, and the rest of the part is going to be in your capsular bag. And this is the knot of the proline suture, which you can see. Now, you also have some capsular tension segments, which are basically for focal zonular weakness. You can use these capsular tension segments. They are more easy to implant than a Sione ring, hence preferred by few surgeons. So they can be a 120-degree arc with a single fixation eyelet, or you can, this is called the Ahmed CTS, or you can have an Ambati CTS, which has two fixation eyelets for a uniform distribution of the traction when you're fixing it to the scleral flap. That's about the instruments of cataract surgery. And next, we will move on to the instruments of corneal surgery. Now, these are certain rings which are called Flerenga ring. They are used in keratoplasty to stabilize the globe and avoid a globe collapse after the host trepanation has been done. The size, it comes in various sizes. Size varies from 12 to 22 millimeter. And as you can see in this, this is the Flerenga ring, which in this was a case which was a vitrectomized, it was a vitrectomized eye with an AGV in situ, hence the chance of a globe collapse was high. So this ring was placed at beyond the limbus. It was sutured at 3 to 4 millimeter distance with a 80 vicryl suture. The advantage is specifically in aphakic eyes, vitrectomized eyes, pediatric eyes, and pseudophakic eyes, where the risk of globe collapse and keratoplasty is high. However, the disadvantage of this ring is that it may distort the shape of the globe and cause an oval trepanation, and high astigmatism can be there when you are suturing. Hence, it should be used cautiously. The placement should be proper. Now, this is a corneal marker. Now, this has a handle with a ring attached to it at the end, and it has a depth to it. It is just not a simple ring. It has a depth also to it. Now, it is available in various diameter. It is not just used for marking of the cornea, but also sometimes when you have to do an alcohol-assisted epithelial debridement in photorefractive keratectomy or phototherapeutic keratectomy or in CXL, you can use this as an alcohol well for putting in alcohol in this area, and you have a focal exposure of the corneal surface with alcohol to avoid spillage onto the surrounding structure, as the alcohol can be toxic. And then you can remove the epithelium after the contact time is over. In addition to that, you can have the marking on the corneal surface with an 8 or 9 millimeter ring when you're doing a DSEC or a DMEC, because this marking will guide in your descent membrane stripping so that you have an adequate size of strip of the descent membrane in DSEC DMEC surgeries. Now, this is an RK marker, also called the radial keratotomy marker. RK stands for radial keratotomy. However, the purpose now for this instrument is for keratoplasty because arc is not done anymore. Now this is an handle, a metallic handle to which are attached radial claws to this circular ring. It comes in different types. It can have 8 claws, 12 claws, 16 or 32 claws. So they are basically for marking on the corneal surface to achieve good marks on the corneal marks for having a good suture alignment in keratoplasty. However, the disadvantage is that if the marks are thick, if you take a lot of GV paint onto this on this radial claw, you will have a lot of smudging of the dye, and then the suturing itself may become difficult because of the smudged dye on the surface. Moving on to the next instrument are the corneotrophines. Now they also come in different designs. So even if you are given one, you will be asked questions related to the other. So you should know about all these. The most common instrument that is used is the central one, that is the handheld disposable trephine. It is easy to use. It is a single-use instrument, has a central opening, hence a good centration of the cornea can be achieved. The disadvantage, however, is that the depth of trephination cannot be adjusted in this instrument. Now, the other instrument is the handheld trephine with an obturator. This is a metallic instrument with a central obturator. The advantage of having a central obturator is that you can adjust the depth of trephination. While you screw this obturator, the blade exposure of the blade gets changed. So the amount of exposure of the blade will determine the depth of your trephination. So that's the advantage of using this, and also it is reusable. The handheld trephine with obturator is a reusable one. However, the disadvantage is the central obturator blocks the central view, and hence to achieve a good centration onto the corneal surface is difficult with this instrument. The other instrument, corneal trephine, is the Hesburgh-Baron trephine. Now, this is a suction trephine. So you can see there is a cross here. This black circular ring has 4 pins at its edges. This is called a crosshair, and the central area is open through which you can actually see the corneal central marking that has been done. So a good centration can be achieved. Now, this is attached to a plastic tubing, which is attached to a plastic 5 ml syringe, which has a spring attached to the distal plunger. So unless you will not, this spring makes sure that the plunger is open at all times unless you try and push the plunger to close it. Okay. So the main function is that when you want a good suction trephination, you push the plunger so that the marking is at 0, the plunger reaches 0, and then you place this trephine onto the cornea and achieve a good centration, and then release this 5 ml syringe. So with the 5 ml air that has been aspirated, it is going to build up a vacuum, because of which your trephine is going to get stuck to the corneal surface. And hence, during the process of trephination, the trephine will not slip. So you will have a good centered vertical trephination and good edges. Also, you can adjust the depth of trephination by the amount of rotation that you will do at the level of this crosshair. So one quadrant or 90-degree rotation will give you a trephination of 60 microns. They come in, now these trephines come in different sizes, 6 to 9 millimeters. So this is just a video to show how a handheld disposable trephine with the rotatory movement of partial thickness trephination can be done. So that's how a partial thickness trephination is done with your handheld trephine. Now, this is a Teflon block. This is a simple Teflon block which has a center curved well. So this curved well is designed to match the contour of the donor cornea. The donor cornea is placed onto this Teflon block for preparation for punching, with the epithelium down and the endothelium up. And the trephines that we just discussed are used to punch the cornea to prepare the donor corneal rim. Now, the other blocks that can be used for donor cornea preparation are the paraffin block, polycarbonated and nylon blocks, and the Kaufman corneal cutting blocks. The Kaufman corneal cutting block also has a metal cover or a bell to cover this block on which the donor cornea is often kept after preparation. Now, this is a blade breaker. It is a metallic pencil handle with a blunt tip, which gets opposed when this part of the locking system is engaged into the lock. So a disposable razor blade is broken and engaged onto this tip, and this lock is closed to ensure that the blade doesn't move. So it is used for making partial thickness incisions, basically in SICS, SF files, and traps. Now moving on to the next instrument, this is an artificial anterior chamber. So it has different parts. You can see this is the base part on the which is connected to plastic tubings, at the end of which is connected, which also has a locking mechanism, and this end is connected, usually connected to an irrigating system. So you have irrigation system and fluid coming out from the top of this instrument on which the donor cornea is placed, and that is secured in position with the additional rings that you can see at the bottom. So these additional rings are placed on the top of this instrument after your donor cornea has been placed to secure it when further manipulations are being done. It is basically used for donor tissue preparation in DSEC, whether it is an automated DSEC or a manual DSEC. In both these surgeries, this instrument comes in handy. This is a reverse Sinskey hook. So in contrast to the Sinskey that we saw previously in cataract surgery, which had a downward angulation of the tip, this has an upward angulation of the tip. This is used basically for the host preparation in DSEC and DMEC for achieving a desmet membrane stripping. So it has a fine but blunt tip. The tip is blunt so that the stromal fibers are not inadvertently damaged, because a sharp tip will result in damage to the stromal tissue fibers, which is not what we really want. Now, this is a DSEC stripper. The design is similar to that of a reverse Sinskey that you just saw here. Reverse Sinskey that you just saw here, which had a fine tip. Here, it's a kind of a spatula or a broad tip. So where your desmet membrane is scarred and adherent to your stroma, in such situations, a DSEC stripper can be used for removing the desmet membrane for preparing in DSEC and DMEC surgeries. Now, there are various methods of inserting the donor DSEC lenticule in the anterior chamber. One of the common method is the pull-through technique with the help of a Busen glide. So this is a Busen glide, which is a metallic handle with a curved plate attached to it, which has a broad end here and a narrow opening, which is approximately 3.2 millimeter in length. So basically, this broad plate ends up into a narrow funnel. The specific design is to ensure that the DSEC lenticule rolls up to form a scroll, which can be easily injected into the anterior chamber through a small incision, like a 3.2 millimeter incision with a pull-through technique. Now, moving on from DSEC to instruments of DMEC. This is an S stamp. You see, this is an S-shaped orientation, which is attached to a normal metallic handle. This is used for marking of the DMEC lenticule on the desmetic side to help identify the appropriate orientation of the DMEC lenticule once injected into the anterior chamber. So the DMEC lenticule, because it goes in a scroll fashion into the anterior chamber, the unfolding has to be appropriate with the desmet up and the endothelium down. To identify that the desmet is up and the endothelium is down, after opening up the scroll, this S mark is preoperatively put onto that scroll at the time of tissue preparation. Now, moving on to instruments of oculoplasty. That was about the instruments of corneal surgeries. Now we'll move on to the instruments of oculoplasty. This is a Calesian clamp. It has a circular disc a metallic plate, and a circular rim, which is attached to a handle with a screw to tighten this plate to the ring. So basically in chalazion, a pre-op marking of the site of chalazion and it's done, and then a block. You should be aware of all the steps of chalazion surgery. And the advantage of this plate and ring here is that it helps you to have a good stabilization of the chalazion and lid, and gives you a good hemostasis, so that when you're making the nick to curettage the chalazion, you have a lot of bleeding. But with the screw, if you tighten it up, the chalazion is well demarcated within this circle, and also the surrounding vessels get clamped, so you have a good hemostasis. So now this disc has to be on the skin side and the rim has to be on the conjunctival side. The use and application should be known to all of you. And the next instrument for a chalazion surgery is your chalazion scoop. Now this has a cupped shaped ending with sharp edges. So the edge of this is very sharp. So this is basically for curating out the material present in the chalazion after you have given an incision or nick. This is a Jagger's lid spatula. It is a simple metal plate with a flat plate with convex concave surface. And this is basically used when you're doing procedures on the eyelid. Because on the eyelid, when you're passing sutures sometimes may become full thickness. You may have inadvertent needle injury to the globe. So to protect the globe and avoid such a needle injury during lid procedures, this metallic spatula is placed between the globe and the eyelid. So that is the purpose. It is used in entropion, ectropion, and ptosis surgeries. And the convex side is placed towards the lid of the globe. Now, this is a Burkitt's ptosis clamp. This is again a metallic. You have a J-shaped loop and a locking system here. So it has internal serrations as well. So this is basically used for ptosis surgery. This used a lid clamp or a Snellen's entropion clamp. Not very commonly used, but yes, it was used previously. So some instrument boxes in your medical colleges may have these old instruments as well. So it has a D-shaped plate and U-shaped rim with a screw tightening clamp here. And this is basically used in entropion and ectropion surgery. This is separate for the right and left eye. Now this plate, metallic plate, will be on the conjunctival side, again to protect the globe, just like your previous lid spatula that we discussed. And this rim is going to be placed on the skin, and the handle is going to lie temporally at the canthus. It gives a good hemostasis and also protects the globe with the help of this plate. Disadvantage is that it is very bulky, and sometimes pressure necrosis of the tissue can occur if you're tightening way too much with the screw. And because this is a bulky instrument, it reduces the surgical field as well. The next instrument is the Nettleship punctum dilator, which is a conical pointed tip and is used to dilate the puncta prior to probing or syringing. So it is available in multiple sizes corresponding to the probe size. And at this step, you should be aware of all the steps of syringing and probing, and the interpretation of syringing and probing should be known to all of you. These questions may be asked. And these are the Bowman lacrimal probe, which are available in different sizes, varying from size 0000 to 4. And the size single 0 is equivalent to 1 millimeter. You should be aware of what are the diameters and which one to use. First, that you should go with a thin probe and then increase the size. And this is basically used for probing the lacrimal canaliculi and the nasolacrimal duct to find the site of the block, and used in DCR surgeries, also for therapeutic probing in children's. So these questions related to NLDO will be asked, related to syringing will be asked, and you need to be well versed also with the anatomy of the lacrimal drainage system, lacrimal sac, and NLD. All that can be asked when you have such an instrument in hand. This is a Thudigam's nasal speculum, although it is more commonly used in ENT, but for ophthalmic use, it is used for nasal examination and nasal packing during DCR surgeries. and for anterior rhinoscopy and nasal packing in DCR. So how to hold this instrument is something that you need to know. Sometime examiner may just ask you to hold this instrument and you may fumble up. So this is a photograph showing how you hold this instrument. Now, this is a cat's paw lacrimal wound retractor. So it looks something like a fork which has been bent. So it has multiple grooves at its end. So this is just to retract the soft tissue in DCR surgeries, lacrimal sac and lid surgeries, to have a good exposure to retract the soft tissues. And it also gives hemostasis effect with the design that it has. So in this now, incisions, where is the incision for DCR made, and the steps of DCR surgery need to be known when such an instrument is coming up. Next is your Freer periosteal elevator. It has a concavo-convex blunt end and is used to lift the periosteum and lacrimal sac from the underlying fossa. Then you have the Dastur lacrimal sac dissector and curate, which has a metallic handle with a blunt spatula at one end and a fine curate on the other end, again used for DCR and DCT. Then this kerosene bone punch. What you need to understand is that it comes in various sizes from size 0 to 4. The size 0 makes a cut of around 1 millimeter bone chip, whereas a 4 size 4 gives a 5 millimeter bone chip. So you start with a smaller size kerosene bone punch to make the initial ostia in the DCR surgery. So whenever you get such an instrument, you will be asked about what is the anatomy of the lacrimal fossa, which bones are crushed when you're making the DCR ostia, and what are the complications of DCR surgery may be asked. So next is your Wells enucleation spoon, in which Wells enucleation spoon, which has a spoon-shaped instrument with a central cleavage. So you can see there is a central cleavage area, which is for engaging your optic nerve, especially in enucleation surgeries. So this is an enucleation scissor. It is a thick curved scissor with a blunt tip. So after you have engaged your optic nerve with the Wells enucleation spoon, you use an enucleation scissor to cut the optic nerve in enucleation surgery. So here you'll be asked about indications and indications of enucleation surgery, steps, orbital implants, and all these things may be asked to you with this instrument. Next is the Mule's evisceration spatula. So this has a stout, it's a bulky instrument with a metallic handle with a rectangular blade and a convex surface and blunt edge, and it has a convex surface. It is used in evisceration to scoop out the uveal tissue content from the sclera to have a complete removal of the uveal tissue. So again, now here the indications of evisceration surgery and contraindications and the steps of evisceration may be asked to you when you have such an instrument. So that's all from my end about oculoplasty, cataract, and cornea surgical instruments. With that, I would like to hand over the dais to the next speaker for the next set of instruments. I'll be happy to take any questions in the end. And Dr. Farnaz, I think you are muted. Dr. Farnaz, you're muted.
Muted, yeah.
Yeah. Thank you, ma'am, for the comprehensive coverage. So we move on to the next part of today's session of ophthalmic instruments by Dr. Devesh Kumawat. A brief introduction. So Dr. Devesh did his MBBS from AIIMS New Delhi and MD Ophthalmology, and he was a gold medalist as well. FRCS Glasgow, FRC of London, FICO, FAICO Retina, and FICO Uvea. So current position, Assistant Professor at the Dr. RP Center for Ophthalmic Sciences, AIIMS New Delhi. He's the associate editor of Delhi Journal of Ophthalmology and recipient of several awards, including Allergan Academic Achievers Award, Dr. V.K. Kalra Memorial Trophy for the DOS quiz, Best IJO article, Sunny Side Up, Egg with Red Sauce Appearance at Macula, Certificate of Merit IJO for the Cobalt Blue Light Unit, a smartphone attachment for blue light photography, IJO Gold Award for the article on retinopathy of prematurity, and AIOS International Heroes Award. He has more than 80 PubMed indexed research publications, and he's the editor of educational book on diabetic retinopathy by ARC, AIOS Ophthalmology section, the 5-minute clinical consult. Thank you, sir, for joining us, and over to you.
Thank you, Dr. Parnas. In the meantime, is my slide visible, Dr. Parnas?
Yes, sir.
Okay, so again, thank you, Dr. Farnaz. Thank you, iFocus. Thank you, Dr. Santosh Unawar, and thank you, Dr. Praful Marana, for the opportunity where I could present about the instruments. So Dr. Pranita has already covered majority of the instruments pertaining to anterior segment surgery, and a few of the instruments that I would be covering will be same instruments, but then their use will be might be a little different pertaining to retinal surgeries or glaucoma and squint surgery. So beginning with the retinal instruments, so either the instruments could be used for vitreous surgery or for a retinal detachment or buckling surgery. So before coming to the vitreous surgery instruments, so wire speculum, Dr. Pranita has already covered, but yes, when you are doing a vitreous surgery, then you can see on the picture on the right side that the wire, instead of the wire speculum, the self-retaining Baraker eye speculum, it provides a wider exposure of the surgical site, and you can adjust the desired exposure as well. Because here you are going to enter in the sclera, and that may be 3.5 to 4 mm behind the limbus. So you need a good enough exposure all around the limbus, and therefore a wire speculum may not be sufficient in a majority of the vitreoretinal surgeries. Now, coming to the instruments for vitreous surgery, so the most important or the basic instrument that is required for vitreous surgery is the trocar microcannula assembly system. So you have these on the bottom, you can see how does a trocar microcannula assembly look like. On the top, you have different gauges of trocar microcannula assembly system, 23, 25, and 27 gauge. And you have the gauge number mentioned on the handle, trocar handle. On the right side, you can see 23, 25, and 27. They have different color coding as well. Now, if you see the trocar handle, on the bottom left, you can see the trocar handle has a metal cannula which is mounted on it. And when you insert the trocar handle with a metal cannula across the sclera, and once it is penetrated through the sclera, you can see that the trocar handle, it is going quite into the vitreous cavity, reaching nearly till the vitreous cavity center. Whereas the micro cannula, it is just bypassing the sclera and the choroid layers. So once you remove the trocar handle, then the trocar handle, when it is removed, only the microcannula is left behind, and it is snugly fitting into the scleral wound or the sclerostomy. So a combination of the trocar and the microcannula is known as trocar microcannula assembly system. Now, trocar, as I already told, has two components. One is the handle and another one is the needle. On the needle is mounted the microcannula. Now, the sclerostomy, which is made with the help of trocar incision, or the stab wound which is made, it can have different sizes, and accordingly you term the trocar to have that gauge. So it could be 20 gauge, 23 gauge, 25 gauge, or 27 gauge. On the bottom, you can see that at the distal end of the trocar handle, you have 3 mm and 4 mm marks which are there. So you can take these marks on the conjunctiva or at the sclera from the limbus and decide your trocar entries as well. So you usually enter at 3 mm in aphakic patients, 3.5 in pseudophakic, and 4 mm at 4 mm in phakic patients. Now, needle has a very sharp cutting edge, and it usually provides you stab incisions which are almost self-sealing. Mostly in the MIBS, you'll have self-sealing wounds, whereas in 20 gauge, you obviously have a larger wound opening, which is not self-sealing. Now, micro cannula, which are mounted on the trocar needle, they are made up of polyimide. They are preloaded on the trocar needle, and they are again of different sizes, 23, 25, and 27 gauge. On the bottom, you see that it's the inner diameter that we are referring to. So on the top, you have an orange colored top of the micro cannula, and in the middle, you have a sea blue color of the micro cannula, and at the bottom, you have a purple color. So that is 23, 25, and 27. I have no proprietary interest, but it is of a particular brand. And the color codings may be different for different manufacturers or brands. So on the right side, you see that the inner diameter of the metal shaft, which is there in the micro cannula, it is 23 gauge, 25 gauge, or 27 gauge. However, the outer diameter of the metal shaft, if you see, it is a little higher. So the sclerostomy incision, which is made, it is actually of 22, 23, or 25 gauge for 23, 25, and 27 gauge instruments respectively. Now, these microcannulas, on the top, you have in the picture, you have two types of microcannulas. One on the left is a non-valved microcannula, and on the right, you have a valved microcannula. Now, the non-valved cannula doesn't have any valve, and it's a free connection which is there. So when you are in the video, you can see over here that you have to use plugs when you don't have your instruments within the vitreous cavity, or you don't fluid which is going into the vitreous cavity will continuously leak because these cannulas are not valved. And these plugs are usually held with the help of a plug holder. Now the plug holder has a cross arm function. So when you press it, the arms of the distal end or the arms of the plug holder open, and then you catch hold of the plug at its top, and then you release the plug forceps, and then the plug remains in position in the plug holder. And in the arms of the plug holder, you can see there is some depression also which is there. So this is where the depression is there on both the sides. So the plug, it usually fits snugly in this depression. So non-valve cannulas, you definitely need plugs so that there is no loss of the fluid which is there, or there is no loss of intraocular pressure, and there is no sudden hypotony that could occur or globe collapse that could happen during the surgery. Now, valve cannulas, they have made the surgical steps very easy, because when you make an instrument exchange, then you're less likely to have hypotony, less likely to have vitreous incarceration into the port. And that's why these valve cannulas are important. They have a silicon membrane valve at the top that allows movement of the rigid instruments across the valve, but not a free movement of the fluids. So as I already told, valve cannulas, they have an advantage that IOP control is better in valve cannulas and there is no need for plug placement. However, there are some downsides of the valve cannulas as well, that rigid instruments could be inserted easily, but if the instrument has a soft tip, such as you are using a silicone soft tip cannula, then usually the soft tip cannula will bend when it meets the silicone valve. It will bend and it may not be easier to insert. Secondly, since it's a one-way one-way access is there, that the fluid cannot leak out through these cannulas. So when you are injecting something into the eye with the infusion fluid on, such as you are inserting the PFCL or silicone oil, then the intraocular pressures tend to rise very quickly. And therefore, you need to put a vent in a different trocar microcannula, different port, so as to decrease the intraocular pressure. So that is a downside of valve cannulas. Now, the advantages I've already told, that the trocar microcannula, why it is required. Why can't you just make a stab entry using your trocar, using your MBR blade into the sclera, and then insert your instruments through the sclerotomy wound only? You need these trocar microcannula or microcannula in place so that it maintains, firstly, it maintains the alignment between the entry holes in the conjunctiva and the sclera. Usually you drag or displace the conjunctiva and then make a biplanar entry using the trocar handles. And so the entry holes in the conjunctiva and the sclera, they are not normally at the same location. So in case you are making a sclerotomy only with the MVR blade, then that alignment between the conjunctiva and the sclera, it will be very difficult. Every time you have to insert through the conjunctiva with the instrument at a different location and then in the sclera at a different location. So that will be difficult. However, with the microcannula in place, this alignment is maintained. Second, it provides an unobstructed instrument access. Third, it limits damage to the sclerotomy edges. So if there is no microcannula, so every time the instrument will hit the edge of the scleral wound, and that will cause damage and further opening up of the scleral wound. Fourth, it tends to create less traction on the vitreous base because you have already bypassed the vitreous base with the help of that microcannula. So your instruments are entering and they are directly entering into the vitreous cavity in the center of the vitreous cavity. They are not actually passing through the vitreous base every time. Next, you have the infusion cannula. So in the video, you can see that you're connecting a infusion cannula to the microcannula, which is there. So the infusion cannulas, they are used to introduce the irrigating solution into the vitreous cavity. And the tip of the infusion cannulas, you can see in the middle picture that usually we use a 4 mm length infusion cannula, and that is sufficient enough to the sclera and the choroid, not the retina, sorry. But in certain situations, you tend to use 6 mm long cannulas where there is a choroidal detachment or there is choroidal edema or congestion, in which you think that the choroid is very thickened and your 4 mm length of the cannula might not traverse the whole length of the sclera and the choroid and might not be in the vitreous cavity. So on the bottom right, you can see that in case there is a choroidal detachment and you're using a 4 mm cannula and the choroidal detachment is there in the location in which you have made this, you have put in the microcannula. So if you're using a 4 mm cannula and the tip is still in the suprachoroidal space, then if you turn the infusion here, then the suprachoroidal fluid will increase, and the choroidal detachments will increase. Similarly, if you have an anteriorly dragged retina and you tend with the 4 mm cannula, you tend to enter into the subretinal space. Switching an infusion can make your surgery worse. So that is why a 6 mm cannula can be used in conditions where you have thickened choroid in the area of the pars plana, or you have choroidal detachments. Now, vitrectomy cutter, partly Dr. Pranita has already told the principle. So generally, if you see the older vitrectomy cutters used to have a rotating mechanism of cutting. All the cutters, they are based on inclusive shear force. They utilize suction in which the vitreous is sucked into and then it is cut. So in the beginning, when the VR surgery had just started in 2 to 3 decades earlier, uh, the cutters used a rotating mechanism. Now, what do you mean by rotating mechanism? Broadly speaking, you have a metal shaft which is there and a outside cylinder and a metal shaft. Now, the metal shaft, it moves across the port which is there in the outer tube. And so initially there is some suction. The vitreous is sucked into the port, in metal tube or the cylindrical tube. And then the shaft, it moves across the port and cuts that aspirated vitreous. So this is a to and fro movement, which is there in the guillotine type cutters. But initially what used to happen is the inner shaft used to rotate and not move across the port. So when it used to rotate, in a single direction, then the risk of vitreous pooling and traction was very high and iatrogenic breaks used to happen more. Then came oscillating type of cutters in which the inside shaft did not move in a single direction, but it used to oscillate. That is, moved to one side and then again change its direction. So here the vitreous pooling and traction was reduced as compared to the rotating mechanism, but still it was there. And the guillotine type cutters, they provide the least risk of vitreous traction, because here the inner tube or the shaft, it slides across the port, thus it cuts the vitreous as soon as it is aspirated. Now, like the initial vitrectomy cutters were they used to run on electricity. That is, electrodynamic cutters were they were electrodynamic cutters. They used electricity to drive the motor which was there, and these cutters were very heavy and they used to cause tremors while you used to operate, and fatigue as well. Now, nowadays we are using pneumatic cutters for the past maybe 2 decades. And in pneumatic cutters, you use pressurized air to drive the diaphragm. So there are two parts of a vitrectomy cutter. There is a cutter housing, which is which has a house diaphragm and a spring, and then you have a cutter tip. Now, cutter tip has concentric cylindrical steel tubes that I've already told that there is an outer tube or a cylindrical tube, and there is an inner shaft. Now, the cutter housing has a diaphragm as shown in this picture on the right. You have a diaphragm, and then there is a pneumatic drive inlet, which is shown by the arrow. So you have a gas or a pressurized air which is coming and it pushes the diaphragm down. And so the inner shaft, it moves across the port. And now there is a spring which is there in between the metal shaft and the diaphragm. And this spring, when the diaphragm moves forward, the spring gets compressed. And when this spring recoils, then the diaphragm moves back. And this time, with the recoil, the shaft again moves to its normal position. So then the cutter port opens up. So this is the basic mechanism of pneumatic cutters. Now, the conventional spring-based cutters, I've already told that they use pneumatic drive to push the diaphragm and the inner blade across the port in one direction, and the spring recoil, it brings the blade back to the original position. However, these spring-based cutters, they have a limitation that they provide only a lower cut rate of up to the order of 2,500 cuts per minute. Nowadays, we are using dual pneumatic cutters in which you have, instead of the spring, you have two pneumatic inlets. One inlet is for the to movement, and the another inlet is for the flow movement of the diaphragm and the inner blade. So both the to and fro movement of the diaphragm and the inner blade, it is due to the pneumatic drive, and therefore there is a possibility that you can control the duty cycle over here. So with the same cut rate, you can have the port open at different amount of time. So suppose you are using a one cut rate per minute cutter. That means in a single minute, it is going one time across the port and it is cutting the vitreous only once. But out of that 1 minute, it is possible that 50 seconds out of 60 seconds, the port is remaining open. Or it is also possible that only for 30 seconds, the port is remaining open. Or it is also possible that 10 seconds out of 60 seconds, the port is remaining open. So how much time the port is remaining open, that will decide how much vitreous is getting aspirated. So greater the amount of time the port is open, more amount of vitreous will be aspirated. And so the more amount of vitreous could be cut with the same cut rate of 1 cut per minute. However, since more vitreous is aspirated, the risk of vitreous traction could be more, or risk of iatrogenic damage to the retina could be more if you're dealing with vitrectomy in the peripheral retina, where the retina is detached and more mobile. Now, the dual pneumatic cutters, they provide you a higher cut rate as compared to the conventional spring-based cutters, that is up to the order of 5,000 to 7,500. Now, there is a recent advancement that has come in that you have twin dimensional cutters as well. So the inner shaft, instead of the inner shaft, you have a inner shaft has an opening in itself, other than the opening in the outer port. So in the TDC cutter on the left, you can see that as the inner shaft is moving to and fro, it is cutting at both the times. However, in the classic cutter, it's only when it is moving to and moving across the port, it is cutting the vitreous. While it is going back, it doesn't cut the vitreous. But because there is an opening which is there in the inner shaft as well, so when it is moving fro, it is cutting the vitreous at that time also. So you can understand that the cut rate now increases from maybe 5,000 to 10,000 or 7,500 to 15,000. So it doubles up, and the port is nearly always open. So more amount of vitreous could be aspirated and cut in the same given amount of time. Now, you may be asked, what is a conventional vitrectomy system and what is minimally invasive vitrectomy system or microincisional vitrectomy system? in your instrument viva, when you are shown these vitrectomy cutters, you may be asked what is conventional vitrectomy system and what is microincisional. So 20 gauge cutters are basically your conventional vitrectomy system, and the microincisional vitrectomy systems are your 23, 25 or 27 gauge cutters. Now you have different bores or different thickness of these vitrectomy cutters. So on the bottom left, you can see the 20 gauge vitrectomy cutters. It has a thickness of 0.9 mm, 23 gauge of 0.7 mm, 25 gauge of 0.5, and 27 gauge of 0.4 mm. So 27 and 25 gauge are usually self-sealing. However, 23 gauge requires suture sometimes, and 20 gauge always need to be sutured. The concerns which are, however, there with the MIVS instruments such as 25 and 27 gauge is that because they have thinner metallic tubes or metallic shaft, they are less rigid and they can bend and break at the proximal end of the cutter tip. So now you have additional plus instruments like 25 plus as 27 plus instrument, which could be there, meaning there is an additional 5 mm sleeve which is there at the proximal end to make them more rigid. So overall, you should know that minimally invasive or microincisional vitrectomy systems are better when you are looking at wound integrity and need for sutures or self-sealing wounds and wound recovery and healing as well. And but there is one downside that they are less rigid and they can bend and break. Now, next instrument other than the vitrectomy cutter, the next important instrument is an endo-illuminator. So you need an instrument or a light source to illuminate whatever you are visualizing in the posterior segment. So commonly you have the xenon illuminators and LED lights in current today's scenarios. Previously, the light sources were either halogen-based or metal halide lamps or mercury vapor-based. Now you can have straight or focused endo-illuminators or those with diffuse or wide field light, or sometimes you have shielded with hood on one side that will prevent light being reflected toward the surgeon and will decrease the glare. Now, another illumination source is a chandelier. So traditionally you have three ports that you make. One in the infratemporal quadrant for infusion, then another in the supranasal, and another and the third one in the supratemporal quadrant for the endo-illuminator and vitrectomy cutter. Now, sometimes you need to perform bimanual surgery, and therefore you might need a cutter in one hand and a forceps in another, or you might need two forceps in either in both the hands. So therefore, you need an independent light source which need not be held with your hand, so that your second hand becomes free. So here, chandelier illumination, basically it's a similar kind of instrument which is similar to the endo light, but here it could be fixed to the microcannula and you need not hold it. And it provides a diffuse illumination, and you can perform bimanual surgery such as dissections in diabetic retinopathy or proliferative diabetic retinopathy with bad tractional detachments or with foreign body removal cases. Coming to forceps, now forceps, Dr. Pranita has already discussed about certain forceps, but here we are dealing with the microvitreoretinal forceps, such as the ILM and grasping serrated and foreign body forceps. So ILM forceps, basically, if you see, it has fine tips at the end. It has fine tips and there are smaller jaws. Now the jaws are there so that it can pick delicate tissues such as ILM. And ILM forceps are used for ILM peeling in macular surgery. Not only for macular surgery, ILM peeling forceps have use in peeling any delicate membranes, such as it can also be used for maneuvering your capsular excess when it is running out or when it is fibrosed. Then also you can use ILM forceps for capsular excess as well. Now this video, you can clearly see that the uh, the the tips are fine, the jaws are small, but in between them there is a gap, and you can clearly see what retinal tissue you are pinching. So you can see through between the gap between the two blades that yes, it is only the ILM that you have pinched, or you have not inadvertently taken the retinal tissue in your pinch. Now, end grasping forceps, as you see on the image on the top, that it has flat tips. There are no jaws, but The tips have some serrations, minor serrations. It has a grasping platform. Now it is used to grasp a little thicker membranes such as apiretinal membranes. In this video, you can see that there is an apiretinal membrane, and you need to hold this apiretinal membrane firmly so that it could be removed. If you use an ILM forceps over here, you will end up breaking the tissue, and the membrane will come in piecemeal. However, with an ungrasping forceps, you get a good hold. So you can use it for peeling of apiretinal membranes, PVR membranes, and subretinal band removal as well. Because in subretinal bands, if in case you use an ILM forceps, the ILM forceps can break your subretinal band instead of grasping it. Next, you have the serrated forceps. These have large flat blades without jaws, but there are prominent serrations, more prominent than the end grasping forceps, and it is to have a even further stronger grip during membrane peeling. So if there are very thick membranes which you are not able to hold with the end grasping forceps, you can use these serrated forceps as well. Next, you have the foreign body forceps. These are again even larger forceps which have very stout jaws, and they could be serrated or they could be diamond dusted so that there is a firm grip on the foreign body. Because the foreign bodies often could be very smooth and they could slip. So therefore, you need stout jaws which provide with the serrations or diamond dusted tips so that you have a firm holding on these foreign bodies. And you can see in this video, there is a foreign body forceps with large blades and stout jaws, and so that it has a very firm grip on the foreign body, and the foreign body doesn't fall back when you're removing it through the sclerotomy incision. Next, you have the Charles flute needle. So this needle, if you see, basically it has a handle which is detachable, and there is an opening in the handle you can see. And on one end of the handle, you have a option of putting a soft tip cannula. So once the tip of the soft tip is in the vitreous cavity, and this port on the outside is open, then the fluid will come from the vitreous cavity automatically outside because of the difference in the pressure which is there internally in the vitreous cavity as well as the atmosphere. So egress of fluid occurs when the cannula tip is in the fluid and the exit port is open because of the infusion pressure which is there. Now, this instrument, Charles flute needle, it is used for controlled passive extrusion, not for active extrusion, but for controlled passive extrusion of any fluid in the vitreous cavity. More commonly, it is used for removal of the subretinal fluid, which is residual. Subretinal fluid, if you have removed by active extrusion and there is some residual fluid, which is shallow fluid, which is left, you can use this Charles flute needle to have a controlled passive extrusion without the risk of iatrogenic damage due to active aspiration. Or pre-retinal bleed, which is there, you want to passively remove it, you can use this instrument as well. Now you have a backflush active aspiration as well. So you have a tubing which is there at one end of this aspiration system. Now this tubing could be connected to the vitrectomy console, and you can have active aspiration as well. So instead of the passive aspiration which was there because of the atmospheric difference, here you have an active aspiration because of the vitrectomy console, you can have an active aspiration. Now another advantage in the backflush is there is a large silicone reservoir with an opening. Instead, in the Charles flute needle, there was a metal handle with an opening. Here you have a large silicone reservoir along with an opening. Now, when you press on this silicone reservoir, then the fluid, it flushes back into the vitreous cavity. So that function could be used to disperse any sedimented pre-retinal bleed when you're dealing with patients of vitreous hemorrhage due to diabetic retinopathy or venous occlusions. So when you see that the pre-retinal bleed is sedimented and it's not easy to take with active aspiration, then you can press the silicone reservoir that will flush some fluid into the vitreous cavity, and that will disperse the sedimented bleed. So that is an important function of backflush. Another important function is that accidentally you have aspirated some tissue, so then also you can press the backflush, and that will release the accidentally aspirated tissue. Now, next is a soft tip silicone cannula. So that is usually placed onto the handle of Charles flute needle or the active extrusion, or when you are when you want to inject any dye into the vitreous cavity, or tricot, or even PFCL. So there is a soft flexible tip at the cannula tip, which provides automatic entry through the retinal breaks when you want to cause when you want to do a drainage of the subretinal fluid. So you can insert this soft tip cannula through the break into the subretinal space and then aspirate the subretinal fluid, so that you have a flattening of the retina during fluid or fluid air exchange. You have dual bore cannulas, which are important when you are using valved systems, valved microcannulas, because as I already told that the pressures increase when you want to inject any PFCL or dye. So these dual bore cannulas not only have an opening at the tip where you are injecting something, you have openings on the in the shaft at different levels, and at the proximal ends also, which is outside the eye. So when you're injecting something, due to the passive atmospheric pressure, the fluid in the vitreous cavity, it leaks out and it maintains a constant intraocular pressure during injection. Diamond dusted membrane scraper, it's an important instrument used because of its fine abrasive action. It has a tongue-shaped soft silicone which is dusted with diamond-headed tip that provides an abrasive surface, and it is used to create ILM fracture. In beginners, if you're not confident of using or the pinch and peel technique of ILM peeling, then you can use a diamond dusted membrane scraper to scrape the ILM or create a fracture of the ILM and then grasp the edge in peeling. It can also be used to find and grasp the edge of epiretinal membrane as well. Retinal pick, not commonly used nowadays, but yes, was used previously, and some surgeons may still use it. And it has a metallic shaft with a bend at the tip. So in the right bottom image, you can see in the inside, you can see there's a angle tip which is there. It is not very sharp, but it is a 0.5 mm angle tip which is there, and it could be used to induce PVD near the optic disc, or even for ILM peeling initiation or lifting the epiretinal membranes. Similar function is of the finis flex loop, like of DDMS and the retinal pick. But here, what is different is there is the nitinol loop that comes out of this metal tube. So the length of the nitinol tube loop is also adjustable. It could be retracted at different lengths, and it has fine abrasive surface which is there. In the bottom picture, you can see the nitinol edge. It has a consistent contact profile, and it provides a better scraping and initiation of ILM peel as compared to your DDMS instrument. Now you have horizontal and vertical cutting scissors, microvitreoretinal scissors. So horizontal cutting scissors have cutting edges that move conformal to the retinal surface. So the blade generally have a gentle curve, and these are used for delamination during membrane removal. So the blades of the scissor, they are parallel, almost parallel to the retinal surface. Because there is a curve in the blades, and you insert this scissor between any membrane and the retina, and you cut the connections between the membrane and the retina, and therefore it helps in delamination. However, the vertical scissors, if you see, they have vertical blades with pointed tips, and now it is the proximal blade that is moving toward the fixed distal blade to cut the tissue vertically. So the distal blade, it removes fixed, the proximal blade moves to and fro, and so you can segment any membrane which is there. So delamination is possible with horizontal scissors, and segmentation is possible with vertical scissors. Endodiathermy, here it is important that it's a bipolar diathermy, and it is important that when you are it is also important when you are dealing with patients who have pacemakers. So you should know that it's a bipolar diathermy, and if you are operating on such patients, then you need to set your pacemaker off on a different mode. And the uses of the diathermy is for achieving hemostasis. Whenever there's a retinal bleed and you want to diathermize it, then you can use this endodiathermy probe. Or you want to mark the breaks, then also you can use this, because once you do a fluid air exchange, then the visualization of small breaks might be difficult. But once you mark the break with the diathermy, then the edges of the break appears white. And and also endodiathermy is used to make retinotomies. When you want to make retinotomies to drain the fluid from posterior part, then you need endodiathermy to diathermize the retina and then open the diathermy area with using a soft tip cannula. Next, you have endophotocoagulator that is used for retinal laser. And nowadays we are using 532 nanometer green laser. It is the frequency doubled Nd:YAG laser that is used. Argon laser was previously used. And you can have straight as well as curved tips that have different use. Viscous fluid control system is used to inject silicone oil into the vitreous cavity as well as extract the viscous fluid from the vitreous cavity. Fragmentome, as Dr. Pranita has also touched upon, but the difference over here is the fragmentome, which is for vitrectomy system or the fragmentation in the vitreous cavity. It has a longer tip because you want to go very deep into the vitreous cavity and close to the retinal surface, because you want to hold the piece that has fallen off behind and bring it in the mid-vitreous cavity and then give phaco and emulsify it. So the principle remains same, but the difference over here is the tip is longer and you don't have a sleeve, because having a sleeve means you will have to make a bigger sclerotomy incision, and we don't want to make a bigger sclerotomy incision because there might be issues related to maintenance of intraocular pressure. There would be leakage, and later on the sclerotomy incisions would require more sutures. Commonly, the fragmentomes are 20 gauge, and therefore they require 1 or 2 sutures normally as well. Now, intraocular magnets and extraocular magnets are also important instruments. Intraocular magnets are used to remove the foreign bodies from the posterior segment, either by the sclerotomy route or through the limbal route. And when you are coming out of the wound, then you can use the external rare earth magnet also, so that the foreign body doesn't fall back into the vitreous cavity, because often you face problem when the foreign body gets stuck in the wound when you're removing it. So you should be liberal in making the wound, and always keep an external magnet so that the foreign body doesn't fall back. 41 gauge needle, I think I'll skip this thing. Now next is the retinal viewing system during vitrectomy. So you might be asked about the wide angle lens, which are used for viewing during vitrectomy. And you should know briefly about the macular viewing lenses as well. So wide angle viewing lenses, you have different varieties of lenses which provide a wider view of fundus and allows peripheral vitrectomy as well. They could be contact as well as non-contact. And contact wide angle lenses, they require an assistant to hold the handle. And they come in pediatric as well as adult sizes. On the other hand, you have non-contact wide angle viewing systems. There are different types. Reset and Biome are two of the examples of such a system. It doesn't require an assistant to hold the lens handle because it is mounted on the microscope itself. And there are different lenses for wide angle viewing as well as for macular viewing in these systems. Now, talking about the macular viewing or the high magnification lenses, you can either have the non-contact system that are already shown, that you have different lenses for macular viewing. Then you have irrigating lens or the Challam lens. So irrigating lens is basically is a plano-concave lens, 45 diopters, and it provides nearly a 30 to 35 degree field of view. And again, it has a handle and the assistant holds it, and there is an option of infusion fluid that could be connected to it, so that because you need a coupling medium here, because you are keeping this irrigating lens over the cornea, so you need a coupling medium. Either you can use the infusion fluid which could be connected to the tube, or sometimes you can also use a viscoelastic agent that could be put between the lens and the cornea. Then you have the self-stabilizing Challam lens where assistance is not required and you have a stable view. However, the field of view in this lens is only 15 degrees. Now, there are different dyes that are used in vitreous surgery, and you might be asked about these dyes as well. So commonly you have the BBG dye, then you have the trypan blue, and another dye which was used previously but not used nowadays is the indocyanine green dye. And triamcinolone acetonide is not a dye because it doesn't stain the vital tissues, but it delineates your vitreous because it gets entangled between the vitreous fibrils. So ideally speaking, it's not a dye. Now, BBG dye, it is useful in staining the ILM, and it negatively stains the ERM. As it stains the ILM in the areas of ERM, the ILM will not be stained, so it will stand out. That is negative staining. Then you have trypan blue, which is for staining for retinal membrane. However, the difference between this trypan blue and the trypan blue used for staining in capsular axis is that this trypan blue is 0.15%. That is, it is more concentration is used. In anterior segment surgeries, you use a lower concentration of dye. Then triamcinolone acetonide, it highlights the vitreous as already told, and indocyanine green, it was used previously, but because of the toxicity, phototoxicity, light-induced toxicity, it is less commonly used or rarely used nowadays. Now, coming to the instruments that are used for buckling surgery or RD surgery, Westcott Caesar has already been talked about with Dr. Pranita. It is used for cutting the conjunctiva and the tenons when you're doing peritomy for retinal detachment or buckling surgery. Stevens stenotomy Caesar, it is used for once you have made the peritomy. So you can see in this video that the Stevens stenotomy Caesar is used to separate the tenons from the sclera. And once you have separated the tenons from the sclera, then only you can hook the muscles and put your explants. Otherwise, it will not be possible to insert your explants. Now, forceps, limbs and serrated forceps have already been talked about. Now, muscle hooks are something very important, and you might be asked about the muscle hooks, not only pertaining to external retinal surgery or RD surgery, but also for squint surgery. So these are the different types of muscle hooks which are there. First, you have a look at the gas hook on the top left. So it's a band which is there, and the ends of the metal handle are smooth, and there is an eye which is there. So you can bridle this eye with a suture and then pass it across the muscle, and that can help you, that will ease the process of bridling the muscle as well. So this is the gas hook. But the gas hook, the problem is there is a chance of slippage of the muscle that happens because you don't have a bulbous end, or you don't have a J-shaped distal end. Next is the Graphase hook. Graphase hook has a slight bulbous end, but again, it's an L-shaped, it's not J-shaped, so the muscle can slip. Green hook has a distal bend, which is there, but it is very sharp. And it's a J shape, and its tip is a little bend and it is sharp. And it will allow, it won't allow a slippage of the muscle, but however, it could be traumatic because the distal end is very sharp, and the muscle fibers, if you are not careful, they could get injured. Now, Jameson's hook is the most preferred by surgeons who perform the retinal detachment surgeries or squint surgeries when they want to hook the muscle and then bridle them, because in addition to the J shape, which is there, that allows you good hooking of the muscle, it also has a bulbous non-traumatic end, and therefore it doesn't allow the slippage. Now here you also may be asked that how do you hook the horizontal and vertical recti muscles, and there's a particular direction in which you need to hook these muscles, not for all, but for the superior rectus and as well as lateral rectus. You need to hook both of these muscles from the supratemporal side, because for superior rectus, if you start hooking it from the nasal side, you have the risk of inadvertently taking the superior oblique along with it, and pertaining to lateral rectus, when you're hooking it, if you hook it from the inferotemporal quadrant, then you have a risk of hooking the inferior oblique if you go too posteriorly. So the safer quadrant for hooking both the superior and the lateral rectus would be the supratemporal quadrant. Now, Castro-Visual caliper is important for measuring the distance from the limbus to the sclera, for taking your suture bites for your explants. So Castro-Visual caliper is very important. Then Desmar's retractor, again for retracting the soft tissues when you want a good view of the sclera near the equatorial area where you want to place your sutures for the band or the buccal, then your Desmar's retractor is very handy. Scleral indenter or depressors, there are different kinds, and on the left you have the Shippen's depressor, which is a solid depressor, and it has a metal end, and there's a T-shaped end, And the problem is that it is difficult to grasp the proximal solid end. While the thimble depressor, you have the option of inserting your index finger or your thumb in the proximal end, and that provides a little that makes the indentation process a little easier. Then you have the Shocket depressor, that is the most preferred one, because you have on one hand you have a bulbous one end that provides you a narrow indent, whereas the other end is a T-shaped end which provides you a broader indent. And so you have different indenters for pediatric population as well, because both the ends in pediatric population, they are more fine and smaller. Next, you have the gas RD hook. Now, gas RD hook, if you see, it has a metal shaft, and there is a small band which is there, and it is not very sharp. It's a band distal tip which gives you a small indent or impression on the sclera. When you press it on the sclera, you get a small indent or impression. Now, this gas RD hook is for localization of the retinal breaks onto the sclera. So when you're indenting on the sclera, you know where the break is when you are visualizing it through indirect ophthalmoscope. And once you have pressed the sclera from outside, and when you're sure that this is the location where the break would fall, so with the gas RD hook, you mark it. You can use a die also to mark. You can use the die at the distal tip and then take a mark on the sclera. Castrovizio needle holder and Baraker needle holder already been talked about. Now, coming to the silicone explants, you have bands as well as tires and silicone sponges that were used previously, but less commonly used nowadays. So silicone encircling bands, the common styles that we use are the 240 band. And you might be asked about what is the width of this band. So it is style 240 has a 2.5 mm width, and it has a length which is nearly 125 mm. So it is enough to cover the equatorial area of even pathological myopes or high myopes. And this circling band, then you might be asked about where are the sutures placed. Generally, you place the sutures for a 2.5 mm width band, you place the sutures 4 mm apart, so that you have some wrapping around of the sclera around the band, and you get an indent. And these sutures are usually placed at 14 mm from the limbus, around 14 mm, because there approximately the equator will lie. Another landmark will be the vortex veins, that the distal suture could be taken as just proximal to the vortex vein, and then the anterior suture bite could be taken 4 mm anterior to the distal bite. Now you have tires which are of different sizes and shapes, and you have symmetrical tires or asymmetrical tires depending on where the groove is. So the odd numbers usually are the symmetrical tires. So you have 277, 279. The groove in this, if you see the cross section of the tire, the groove is in the center, that is symmetrical. And then you have even number tires 276 to 276, in which you can see the groove is on one side, and it's a 276 buckle is a 7 mm width buckle along with a groove of 2.5 mm, in which a 240 band will snugly fit in. Now, the asymmetric buckles could be placed in two orientations, where you have the asymmetric end or the longer end closer to the limbus, or asymmetric or closer end away from the limbus. So the main principle over here is the maximum indent will occur in the area of the groove. So in an asymmetrical silicone tire, the indent, the peak of the indent will not be at the center of the indent which you are getting. So if you are placing the groove anteriorly, the peak of the indent will be more anterior. So for dialysis cases or anterior breaks, you can keep the groove anteriorly, and for posterior breaks, you can keep it posteriorly. The silicone sponges, they are out of use nowadays, because earlier they were used uh, um, for radial placement of sponges for more posterior breaks, which could not be covered by circumferential ties and bands. These used to have air spaces, and there was a risk that these could be contaminated with bacterial colonies, and therefore there could be risk of buccal infection. Now, sleeve spreading forceps. So, Watt's sleeve is basically a sleeve that could be used for final tying of the encircling band, which you use. Either you can tie it using a suture, or you can use a Watt's sleeve. And this spreader is again, it is a cross arm fixation function. And when you press the handle, then the tips will open, and so you in the unpressed position, you can insert it into the silicone sleeve, which is on the right side. And when you press the handle, the silicone spreads, and in the silicone sleeve, you can slide your band ends from both the sides and adjust the band. Last, you have the cryotherapy probe. You might be asked about the different cryotherapy probes in general. So you have different cryotherapy probes for retinal cryo, there are different probes for uh, cryo removal of the lens as well, which was done previously, ICC. So there is a technique in which you use the cryo probe for removal of the lens in ICC. So that probe is different. And then you have retinal probes, and glaucoma probes are different. So commonly for retinal surgeries or RD surgeries, we use a probe which has a diameter tip of 2.5 mm. And cryotherapy probes, they are based on the Joule-Thomson effect. That is gas which is at very high pressure, it passes through a narrow orifice and it expands, then it causes rapid cooling of the surrounding structures because it expands. And the common gases used are the nitrous oxide as well as carbon dioxide. And it has this insulating sleeve which is there, and it is important that you have an insulating sleeve in these, so that inadvertent damage to the lids do not occur while using the cryotherapy probe. The use of the cryotherapy probe is to cryo the breaks or even the ischemic retina during surgeries, or port side cryo if you are suspecting a port side fibrovascular proliferation. Then, so laser, most of the retinal breaks could be lasered if they are little posterior, but very anterior breaks, if there are any during the surgery, if you want to even during vitrectomy surgery, then cryo might be required. And during RD surgery, you cryo the breaks, and then you place your explant. Now, this was all about the vitreous and the RD surgery. Coming quickly to the squint surgery instrument, there are not many instruments. Important one is the globe fixation forceps, in which you have uh, tooth, which are there, multiple tooth at the end, and which provide a better grip while holding the conjunctive and apicellary tissue near the limbus. So now you might be asked, what are the uses of this globe fixation forceps? So it is for holding the eyeball firmly. Now in squint surgery, you might want to fix the eyeball not only during the squint surgery but also during the force duction test. That is for holding the eyeball and then checking for the tug of the muscles. So so as to differentiate whether it is a limitation or restriction. So for that purpose, you use a globe fixation forceps. Then artery or hemostatic forceps, it already been talked about by Dr. Pranita, but here it is important to mention that you need it to crush the muscles in squint surgery before cutting them with the Stevens stenotomy scissor. Now, glaucoma surgery instruments, there are two important instruments. One is the Calis punch. Now, Calis punch, it was again in the current scenario, but some examiners might want to ask if the instrument is there in your instrument box. So Calis punch, it is used to make sclerostomy incision in trabeculectomy surgery. So in trap surgery, initially you make a peritomy, and then you make a triangular or a rectangular scleral flap, which is partial thickness. And then the deeper part of the sclera, you have to make an opening. So nowadays you can make that opening using the MVR blades. But another safe method would be using a Calis punch, which is used to make the hemival punches, which are in the deeper sclera. And once you make those punches, then you can see the underlying iris, which then you excise with the scissor so as to create your surgical PI. Now, if you see this instrument, it has a rigid rigid metal blade on one side, and there is a uh, there is a handle which is there, and when you press this handle down, then again there are two metal shafts which are there. So the distal shaft is fixed, and there is a proximal shaft that moves toward the distal shaft when you press this handle. And when the proximal and the distal tips they meet, then they crush the tissue, which is there. They cut the tissue because they are very sharp. So this Cali sponge could be used to make a sclerotomy incision in trabeculectomy surgery. Now, Harm's trabeculotome, it's an important instrument used for trabeculotomy. Here it is different, trabeculotomy. When you want to make an opening in the inner wall, you want to remove the inner wall of the Schlamms canal, that is trabeculotomy. You want to make an opening there. So here, what you do is you initially make the peritomy in trabeculotomy, and then make a scleral flap, again a triangular or a rectangular one. And then you don't do a deep scleral dissection. You just give an incision in the junction of the gray and white area where the Schlamms canal would be. When you give a linear incision, then you can see the opening of the Schlamms canal. And through that opening, so this trabeculotome has long tips, curved long tips, 2 tips on each side, and it is different for inserting on left side as well as the right side of your surgical field. So there are because you want 2 different curves for left-sided and right-sided entry in the Schlamms canal. So wherever you are entering, if you want to break the Schlamms canal on the left side of it, then you would like to remove use one of the trabeculotome, and for the right-sided entry, you need a different trabeculotome. The tips are 9 mm long, and then they are this is the classical size, but you have smaller as well as larger size available as well. So this trabeculotome, one of the end will go into the Schlamms canal, and one of the end will be above the cornea. And when you rotate it, once you have inserted, and when you rotate it inside, so then the inner blade will break off the inner wall of the Schlamms canal, and that's how a trabeculotomy is done. So this was all about the instruments pertaining to retinal surgeries, glaucoma and squint surgery. So I'll be happy to answer any questions which are there.
Thank you, sir. I think you have covered like almost extensively the entire instruments which will actually be asked in the Viva, and including everything else which Dr. Pranita ma'am covered as well. So we don't have any questions as of now. So I think we have come to the end of the session as well. All right. So we'll meet you on the 21st of May, again by Dr. Pranita ma'am. So we'll meet you on the topic instruments, especially focusing on the cornea. Sorry, images, especially focusing on the cornea, which will be on Wednesday. So have a nice weekend. Good night. Thank you.
Thank you.
Thank you, Dr.
Thank you. Good
Pranav.
night.
Thank you. Good night.